Okay, we'll get going and some announcements. We have the first lecture now. It's been archived, and so people can watch it on their computer, videocast.nih.gov anytime. And usually for the rest of the term, 2 days after the lecture will be archived, so you can watch it anytime, as opposed to watching it Monday 4 to 6. And so today we have Ravi Madan talking. He's an associate research physician, and he's going to be talking to us about prostate cancer. We mentioned last week that was one of the 4 big killers. So Ravi got his MD from the New Jersey Medical School, and then he completed internal medicine residency. He then joined the NCI Medical Oncology branch as a fellow in 2005. And he currently has an appointment in the medical oncology branch in the Laboratory of Tumor Immunology and Biology. So today is titled Treatment of Metastatic Castration-Resistant Prostate Cancer. Ravi.
Thank you, Dr. Moody. So yeah, unfortunately, prostate cancer is one of the big, more frequent diseases, with 1 out of 8 men essentially getting diagnosed. So unfortunately, this is one of those things, since you guys are in biomedical sciences and healthcare, this is the thing that people always approach you with. I know somebody, my neighbor, my grandfather, my dad, so these are things that come up just even from a conversational standpoint, unfortunately. Today, I'll be focusing, since we have an hour only, on kind of advanced prostate cancer, because I think from a scientific standpoint, that's probably what's more relevant for your interest. So as opposed to starting out with an outline of what I will be talking about, I'll just highlight what I'm not going to be talking about, because these things can really be addressed in a whole separate lecture unto themselves. So the treatment of primary disease, that means newly diagnosed patients, is primarily managed with surgery or radiation. For the most part, there are no randomized clinical data that shows which is better, which is pretty confusing. So if cancer is localized in the prostate, it's actually difficult for patients, because they can't come to me and I say this is better based on data. So radiation is sometimes curative with potentially the use of androgen suppression therapy, and surgery can also be curative. But again, I'm not going to go into that data, but I can tell you at least up front, there is no randomized data that says which is most appropriate. The other aspect of prostate cancer I won't be talking about today is biochemical recurrent prostate cancer. So these are the 20 to 40% of men who have surgery or radiation with a curative intent, but then are unfortunately not cured and just have a recurrence of disease that's measured by a rising PSA. These patients are traditionally observed or surveilled for a period of time, until which they may be treated with androgen suppression. So I guess for a slide that says what I'm not going to be talking about, that was a lot of talking, and I apologize, but I just want to highlight some of the nuances of these things. But just for the sake, I think, of the time that we do have today, I'd like to focus on how we manage advanced prostate cancer, because that highlights, I think, some of the more salient scientific issues. So when we're talking about advanced prostate cancer, we're talking about a disease state that, again, is initially attempted to be cured with surgery or radiation when it's diagnosed, and it's also castration sensitive. In other words, it's still responsive to hormones, and I'll come back to that, and non-metastatic. These are patients that are curative. For the 20 to 40% of men who I pointed out earlier, for those that recur and have a rising PSA, and this curve represents somewhat PSA but also tumor volume, those patients are then treated with androgen suppression, which again is a way to contain the disease, and I'll come back to that point, and then second-line hormone therapy. Unfortunately, if they're not cured when it's localized, there is a potential for it to become metastatic and spread to other parts of the body, most commonly bone, but sometimes also lymph nodes and liver, as well as lung. Ultimately, over time, the symptoms may increase, and then they may lead to death. Until really 2004, there were no proven therapies that demonstrated the ability to improve survival in prostate cancer that was metastatic and castration resistant. And so in 2004, chemotherapy with docetaxel demonstrated for the first time that we could actually extend the lives of men with prostate cancer. Now, we tried for about the next 6 years to improve on that with a bunch of combination studies, taking your favorite targeted molecular therapy and combining it with docetaxel. And invariably, they all failed. But fortunately, there were some other lines of investigation going on. And we actually had 5 new therapies approved between 2010 and 2015 that were employed 4 different treatment modalities. So the first one actually was, no one ever really talks about the current immunotherapy oncology revolution as having started in prostate cancer, but it kind of sort of did with Sipuleucel-T, which is a therapeutic cancer vaccine. And that was approved in 2010 with data that I'll share with you. So I'll come back and share with you all the data for these approvals. But almost as unexpected was a second chemotherapy was approved demonstrating survival benefit, which was also a taxane, which was surprising. So it's strange, at least on first blush, why 2 taxanes work in prostate cancer, but no other chemotherapies do. And hopefully by the end of this talk, I might postulate a reason for that. Then there are 2 anti-androgen therapies, which I'll, again, get to the mechanism of action later, Abiraterone and Enzalutamide. And they were initially approved for post-chemotherapy metastatic prostate cancer before they were approved for pre-chemotherapy metastatic prostate cancer. So they were randomized phase 3 trials done in both these populations. And then also in 2013, a radiopharmaceutical or radioisotope known as radium-223 was also approved. So you see how quickly we went from basically not having anything until 2004, but then from 2010 to 2014, the population, the treatment landscape got a lot more crowded. So let's start with some definitions. So I mentioned this a couple times already. What's castration-resistant prostate cancer? So this is prostate cancer that is progressing despite castration levels of testosterone. And this could manifest itself in a rising PSA or increasing lesions on imaging. But this is important because biologically speaking, initially, androgens drive proliferation of prostate cancer cells. So once you find out that the cancer cannot be cut out or radiated, to oblivion, you have to contain it. And the best way to contain it initially is to decrease the global androgens of the body and basically deprive it of testosterone, its primary proliferation signal. Now, over time, through mechanisms I'll touch on later, the disease progresses despite these castration levels of testosterone. And so hence the term castration-resistant prostate cancer. Older literature may have referred to this as hormone refractory. Since we think hormonal therapies still work in this population, it's probably a misnomer. But this is an important point. And even for the people listening at home, if anyone in the audience has questions on this definition or other stuff, just interrupt me and during my talk, and I'm happy to answer it. But this is an important kind of characterization of the disease. But I already mentioned that there's 2 anti-androgen therapies approved in castration-resistant metastatic prostate cancer. So why is that the case? And this has to do with the resistance mechanisms that basically develop in prostate cancer once you do androgen suppression therapy. And all these are kind of a mixed bag of things that are possible mechanisms of resistance. AR amplification, that AR is the androgen receptor. So when you deprive the cancer of androgens, it wants to become more sensitive to what little there is, so it upregulates the number and quantity of receptors. Perhaps the most sinister thing is secondary production of androgens. So when you deprive the body of testosterone, what you do is you basically do feedback inhibition through a GnRH agonist that basically sends a signal to your testicles that basically there's enough testosterone, don't produce any more. What the cancer cells can do in their own microenvironment then is produce their own androgens, and thereby in an autocrine or paracrine fashion potentially fuel that proliferation. So it basically, you lower systemic testosterone, but unfortunately it's the androgens that are produced in the neighborhood or the microenvironment of the cancer cells that can still drive the disease. Ligand-independent growth. That basically means that you either have modifications in the androgen receptor or the androgen receptor pathway such that they're constituently active despite the fact that there's no androgen signaling the proliferation signal to the cancer cells. And then there can be intranuclear changes as well, because as you can see, once the androgen receptor is activated through a series of cascade reactions, it gets to the nucleus and interacts with the DNA through androgen response elements, leading to cellular proliferation. I think the intranuclear changes are amongst the ones that are least poorly, or I guess the ones that are poorly understood at this point and least targeted therapeutically, although there are some things being investigated. And I would highlight this review article, I think, as being a very good article that goes over mechanisms of resistance in prostate cancer. Equally, I think, valuable to look at if you really wanted to take a further look at prostate cancer is the clinical genomics done by some of the Stand Up to Cancer Dream Team work. This was published just a little over a year ago, and it highlighted the fact that prostate cancer has a lot of mutations. It doesn't seem that surprising. I think most cancers are driven by mutations, but I think there was some sense out there that maybe prostate cancer did not have a lot of mutations. So what you see here is a kind of a heat map type thing where you see different mutations in a number of patients. You see that I think the average patient had 2 or 3 mutations, which tells you how, and this is advanced disease, but the most common ones that we're seeing in about 60-some-odd% of patients were mutations in the androgen receptor or androgen receptor related pathways. So again, just drives home the point that the androgen receptor pathway is how this disease is driven. Interestingly, a little bit lower on this chart is DNA repair. And this actually came out to be about 20%, these pathways here. And I won't go into that today, but there is strong interest now looking at PARP inhibitors, which are very important for kind of BRCA mutations and other DNA repair mechanism mutations. There's some thought that about 20 to 30% of prostate cancers are fueled by this. So to the point where actually they have received breakthrough designation from the FDA. So even though I won't talk about that this year, maybe if Dr. Moody invites me back next year, I'll have some more definitive data. But I guess we have to see how the rest of this 45-minute lecture goes and how my reviews come out to see if that happens. But just something to be on your radar screen. And again, before we get to the therapies, I think it's important to go through the rules of the game, so to speak. And this is actually something that's very, very tricky. And that is, how do you manage prostate cancer? How do you figure out if a therapy is working? Well, they convened a group called the Prostate Cancer Working Group, pretty original name, in around 2008 and published an article. And it actually mirrored what our prostate cancer team here under the direction of Bill Dayhut was already doing, which was basically PSA is a biomarker. So for everybody who wants to do a clinical trial with biomarkers, I think prostate cancer has one of the best ones in PSA. And guess what? Everybody hates it. So just be aware, biomarkers come with a double-edged sword. The reason why it's difficult is because it's hard to know what to do exactly with that information. Until about the timeline that these guidelines came out, even though institutions like ours were already breaking away from this, there was a sense that if your PSA is going up, a treatment is not working. And once kind of trials were done in an innovative fashion that broke away from those guidelines, recommendations were that we don't really do this in any other cancer where we just look at serum markers in the absence of clinical progression symptoms of the patient or radiographic progression. And essentially, there's strong recommendations now, and there's actually, this is Prostate Cancer Working Group 2. Last year was published Prostate Cancer Working Group 3, which followed up these recommendations, which are don't use PSA as a readout of response to therapy when you have radiographic imaging to follow. I'll tell you, I see a lot of referrals. We have, basically a tertiary type practice here where we see a lot of referrals from the community. This is something that I think a lot of issues still surround. And it's not because there are bad doctors out there. I think a lot of it is because going back to when you have biochemically recurrent disease, so if your PSA starts to come back after surgery or radiation and it proves you're not cured, essentially patients lock on to PSA as being an indicator of their cancer. And when you can't image the disease, and the only way you can evaluate it is with PSA, that's all you have to go on. So you're locked in on it. But once you have imaging, you have to transition the patient to the fact that the imaging is more important. And I can tell you, it's a very hard thing to do. Patients stay locked on the PSA. That means that providers have to spend a half hour trying to explain to the patient that even though they're on a therapy and their PSA is going up, that it's still working. And then they ask, well, why is my PSA going up? And it's hard to answer that question because, yeah, on some level, it's not working as well as it was before, but radiographically, your disease is stable, and that's the most important thing. Some patients have adopted the philosophy of no one's ever died of a PSA, which is true. I mean, it's radiographic progression that unfortunately kills the patients. But I think it's very difficult, and this is something that it's important because almost all the clinical trials I'll show you in the coming slides use radiographic progression as their primary readout of progression. And for example, I've seen patients who've had rising PSAs for almost 2 years and stay on the same therapy. So what that implies, and that's not unique to me or our practice or our treatments, it's a standard therapy. And what that highlights is the fact that by stopping it earlier just because of PSA, you potentially shortchange the patient the clinical benefit, the continued clinical benefit of a therapy that they're on. So a lot of talking on one slide, but it's actually a big deal. And I think it's something that's still not fully embraced by patients or providers in the community. So just something to highlight. And again, my last disclaimer before I actually start talking about therapies is I'm going to list a lot of therapies, and you're going to wonder which one, and I'm going to kind of put it in a way that maybe highlights what I think is the appropriate sequence. But you have to realize there are no clinical trial data yet available that defines how to use these basically 6 therapies that we now have. We went from one therapy where it was pretty easy. You were metastatic, you got chemo at some point. Now we've got 5 or 6, and it's not as clear. So there are several trials that are ongoing, and that'll probably be a several-year process if they yield data at all. So in the absence of data, I will provide you with my opinion of what the sequence should be, and I'll probably highlight that from the get-go. But realistically, when practitioners evaluate these therapies with the patients, you kind of have to factor in what the treatment is going to bring to the table in terms of side effects and outcomes, and what the patient is bringing to the table in terms of their comorbidities. So you'll see that some things specifically don't work with patients who have a seizure history or something like that, but also what they're bringing to the table in terms of their symptoms or their pace of the disease. If they have a high level of symptoms and a high pace of their disease, you're probably going to accept a therapy or be more accepting of a therapy that has more side effects. So what I'll do is I'll go through each treatment. I kind of laid out how I think patients are generally managed, again, based on my opinion, but also I think on some practice patterns. And then I'll go through each individual drug, the data that led to their approval, and then in some big scary screen, I'll show you a bunch of side effects. It's not to think that anybody needs to memorize them or anything like that. It's more just so you understand that this is what factors into that go or no go for a given patient. So it's getting close to dinner time, so I guess we can pretend like we're headed to a restaurant or something. And I think that this is a reasonable way to put forth the treatment options in prostate cancer. And we start off with an appetizer, a first course, a second course, and a third course. And I think that, again, what you'd like to do is maybe sample the most appropriate things from each of the courses here, realizing that maybe in some patients you may have to skip a course or realize that not everybody gets an appetizer. So the first one I'll start off with is with what I've characterized here as the appetizer. Now, this is for now remember, these are all treatments for metastatic castration-resistant prostate cancer. And Sipuleucel-T is a therapeutic cancer vaccine that I think has its best role in early metastatic prostate cancer, where there are minimal symptoms and basically low volume and low pace of the disease. And I'll go over the data with you, which is with substantial controversy in the field to this day. 6 years after this agent has been approved, there's still controversy on whether or not this works. But that's why I made it an appetizer. Not everyone orders an appetizer, but what I would also say is that it's not your main course. You're not just going to go to the restaurant and order Sipuleucel-T and then leave and think that everything will be okay. So it is a different form of immunotherapy called the therapeutic cancer vaccine. So I know in these lecture series, you're going to hear a lot about immunotherapy, and it's mostly going to be in the form of checkpoint inhibitors because that's the majority of immunotherapies that are approved. But this is actually the one that's in the minority of vaccines. And this is actually, in some ways, it's very personalized. What they do is they basically take a patient's peripheral immune cells, ship them to a processing facility, where for 24 to 48 hours, those immune cells are exposed to a target antigen, which is prostatic acid phosphatase, or PAP, and a cytokine called GM-CSF to basically stimulate the immune cells. Think of this as kind of boot camp for the immune system. After 2 days of boot camp, these immune cells are shipped back to the doctor's office, infused into the patient. A full course of therapy consists of 3 infusions done 2 weeks apart over a month. So basically, like an appetizer, you just kind of get it and then you're done. And here's the phase 3 trial again that is with has been scrutinized beyond what you would expect of a successful phase 3 trial. But patients were randomized to basically the vaccine or a placebo. There was a salvage protocol, which has been a point of controversy a little bit, where they took some immune cells and reinfused them back in. But the primary endpoint was survival. And that's based on a series of 2 phase 3 studies that were previously done, where in 2007 or 2008, where they basically had the primary endpoint being time to progression, and those were negative studies. But what they found in one of those smaller phase 3 studies was that the patients who got the vaccine lived longer. So they said, all right, we now understand how this works. Instead of doing a 150 patient or 125 patient study, we're going to do a 500 patient study with survival as our endpoint. And lo and behold, it was a positive study. So this is actually the second time in a randomized study that this treatment improved survival in prostate cancer. Now, remember what we do in clinical trials. We're not smart enough to assess how it's going to impact the individual. So what we do is we assess basically the person in the middle and assume that person's representative of the general population, and thereby come up with numbers like a median improvement in survival of 4.1 months. And this was substantial improvement and clinically meaningful and led to the FDA approval. But the fact that there was no short-term change in progression, everybody pretty much had progressive disease 3 months into this, which is roughly 2 months after they finished therapy. And PSA declines were rare. I've seen actually pretty interesting PSA declines with this treatment, but PSA declines were rare, and therefore to this day, partially because of that reliance I told you about PSA earlier, there is controversy that this data is fraudulent and this treatment doesn't work. And I don't have time, that's a whole lecture into itself. I will tell you that I don't pick and choose my phase 3 data. If the phase 3 data is positive, I believe that the data is real. Again, this is the second phase 3 trial that demonstrated this, same advantage. So, and guess what? 6 years later, we use checkpoint inhibitors, and oftentimes they demonstrate the exact same thing. When ipilimumab was approved in melanoma, no one in my field ever talks about this, but everybody had progression, or not, the median progression was 3 months for all the groups, whereas survival still benefited the immunotherapy. But no one had this controversy with this. The company did some weird things too in terms of public relations that didn't help or endear themselves to the academic world. So nonetheless, I think this therapy works, but what you can tell here is that it's probably something you can benefit from up front, but like an appetizer, you're going to get other things. So generally speaking, if I have a healthy patient who comes in with 1 or 2 bone lesions, and I think that they've got a few years to live and benefit from this, I would recommend them to go on this therapy. Who should get this therapy? This study was actually enrolled about 15% of patients who had already had chemotherapy, but I would still use it in earlier stage disease because I think like a lot of immunotherapies, it works better if it has time. Not surprisingly, what this data and kind of a subgroup analysis demonstrated was that if you had lower tumor burden in the measure of PSA, you were more likely to have a better overall survival benefit. So basically, this is months of survival based on PSA quartiles, and you see the improvements got better as your PSAs were lower. So again, things are slow in the beginning, small volume. This is when the immune system has its best chance, and so these are the patients I would recommend it for. I won't go into a lot of detail. There's a lot of criticism of how does this therapy work. Well, there is actually immune data showing that basically there is immune-specific activation of different components, antibodies, T-cell proliferation, correlating with these outcomes. So there is data on that. And again, I think it's a reasonable thing. Perhaps the best part of this therapy is the fact that it has very low side effects. You know, this has not been, this stroke issue or concern has not been really uncovered further in post-marketing. So I don't think it's a huge deal, but these chills, fatigue, fever, we see that a lot with immunotherapies. So it's very well tolerated. Like I said, just 3 infusions over a month. It is expensive. I'll go over the cost if there's time at the end, but unfortunately, all new therapies are expensive. But that was another kind of thing that this was labeled with. So that's Sipuleucel-T. Again, it's an appetizer. I would use it up front as early as possible, realizing that I'm going to go on and get something for my first course anyway. So who are the patients who should be treated with these first course treatment options? These are patients with minimal to moderate symptoms. So unlike the appetizer group with Sipuleucel-T, who I said low volume, minimal to no symptoms, these are patients who have minimal to moderate disease and moderate symptoms. And these are actually probably the combination of the most effective therapies as well as the best tolerated. And the two are enzalutamide and abiraterone. And they have minimal side effects, and they do work well in this early disease setting. The one difference is that if you order the abiraterone, you have to get a side of prednisone with that. So that's some added, if it's potatoes in your dinner concept, it adds some extra carbs. And in the patients, there are some potential comorbidities just from having prednisone. And I'll come back to why I've listed enzalutamide first and abiraterone second in these two cases. So what is enzalutamide? It is an androgen receptor, again, that's AR here, androgen receptor antagonist. We've had these therapies for a long time. They were developed in the 1980s and early 1990s. Bicalutamide was developed in the 1990s. And this concept is, if androgens basically drive the disease, why not develop a blocker for the androgen receptor? And they did that. And you know what? We used them in the data with older agents like bicalutamide or flutamide or nilutamide, demonstrated subgroups that did well, but there was no clear benefit overall that it led to survival. So the group headed by Charles Sawyers at Sloan Kettering about 10, 12 years ago said, you know what? We have better scientific technology now. I bet you we can come up with a better AR antagonist. And that bet paid off by probably with more than $1 billion, this blockbuster drug here, enzalutamide, which basically had greater binding affinity than our older agents. And then I talked earlier about how basically the androgen receptor translocates to the nucleus, leading to cellular proliferation. This treatment, enzalutamide, prevents, to some degree, androgen receptor translocation to the nucleus, and then within the nucleus, some DNA binding and co-activator recruitment. So it has downstream effects as well. And that was I think probably is part of the reason why we have much better clinical data. And basically, unlike some of the older agents, it doesn't have agonistic properties, which I won't go into too much detail on. And actually, I guess this treatment's worth $14 billion because the company that made it, which is Medivation, just sold itself for $14 billion to Pfizer like 2 weeks ago. So apparently you can make some money if you develop a good drug. Here is the first of 2 trials that demonstrated the clinical efficacy, which is quite impressive, with enzalutamide. These were advanced cancer patients in a time when basically docetaxel was the primarily approved therapy. So all these patients had received docetaxel because when you develop a drug, you go as late in the disease as you can because you get your payoff or your endpoint quicker, and then you get to sell your drug for $14 billion faster. But so that's the first study they did. And what they saw here was basically in the 1,200 patients treated, the overall survival benefit was about 18.5 months versus 13.5 months. Time to progression, mostly radiographic here, again, was about a little over 8 months compared to 3 months. And this led to basically the FDA approving this drug in 2012. And here are the Kaplan-Meier curves. They had also started a study in the pre-chemotherapy setting where patients here had not received docetaxel. And by 2014, this data was also positive. The progression-free survival was, at 1 year, was basically 65% to 15%. The survival rates are not as robust as you'd maybe have expected, and there's a couple of reasons potentially for that, but you see that it's somehow still 32 versus 30 months was statistically significant, and this was approved then in the pre-chemotherapy setting as well in 2014. So some reasons why this overall survival signal isn't as strong as the one-year survival progression could be the fact that there are other available therapies that can impact survival. And indeed, some of these men may have already gone on to get enzalutamide who were on the placebo arm, in the post-chemotherapy setting. This is increasingly a confounding variable in prostate cancer trials. It was probably easier to take an effective therapy and develop a phase 3 trial that can prove that efficacy when you had one therapy in the treatment landscape that I showed earlier. Now that you have 6, there's a debate as to whether or not you can show a survival advantage anymore, and I'll probably come back to that at the end. Side effects. I've said it's very well tolerated, and it really is. Fatigue is probably underrepresented, although the 51% highlights a little bit, but for the most part, patients do very well. Younger patients might feel the fatigue a little bit more, but this is a very well tolerated medication. All really the other things are very minor. The one thing that is important, and we've seen this with other AR antagonists, and that is there is some CNS penetrance of this treatment that somehow can impact patients with a risk for seizure. So if they're on seizure medications, maybe have had a recent stroke, which in advanced age population is possible with prostate cancer, or they have a history of seizures in general, this is not the best treatment for them. So in this setting, it would not be my preferred option. But in the absence of that, it actually would probably be my first recommended treatment for patients with to moderate disease and moderate symptoms. I won't go into it too much, but there is data that shows that unlike Sipuleucel-T, both enzalutamide and abiraterone improve symptoms as well as changing PSA kinetics and progression. So abiraterone is the second option I've listed in the first course. And again, I'd list it number 2 primarily because of the side effect profile and the fact that it requires prednisone. So that's why enzalutamide is a little bit my preferred, presuming that they can, don't have any seizure issues or seizure threshold issues. So what is abiraterone? Abiraterone impacts the other resistance mechanism. So enzalutamide primarily works where the resistance mechanism is probably AR upregulation, although it could impact this mechanism of resistance as well. And that is the fact that, as we become better in our understanding of advanced prostate cancer, we realize that there is the potential for these cancer cells themselves or other cells in the tumor microenvironment stroma to basically biosynthesize their own androgens. So again, this basically means through various enzymatic reactions, they can synthesize androgens in their tumor microenvironment and thereby provide their own growth signal, even when you've globally suppressed testosterone. So basically, this agent called abiraterone blocks 2 enzymes, the CYP17 alpha hydroxylase and also the lyase component, which basically diminish these other cells from producing androgens. I will take a step back and say that all these metastatic castration-resistant prostate cancer patients and all these studies being done include testosterone suppression in the background. I didn't mention that earlier, but that's because if we let testosterone return to normal and they have all these other upregulated receptors or other androgens in the tumor microenvironment, the cancer would do a lot worse. So we do our best to suppress the global testosterone, realizing we also have to attack testosterone in the tumor microenvironment. So this is the mechanism of abiraterone, which was also developed in the around 2005. And this was not actually a brand new concept either. For historical purposes, there was a drug called ketoconazole, which, as you can tell by its name, was developed as an antifungal in the early 80s, and for some reason had an impact in prostate cancer in at least some groups of patients and was tested extensively. And there were it was unclear exactly how it worked, but it was thought that one of the prevailing opinions was that it worked through these enzymes on secondary androgen production from the adrenal glands. That was actually what was really thought, and we've become more enlightened in the last decade. But again, this was Cougar, I think, was the initial Cougar Biopharmaceutical in England, said, you know what, we can build a better mousetrap. So they did. So it just goes to show, sometimes older ideas can be improved upon, and we've seen that with these two drugs. So much like enzalutamide, the Abiraterone company did two studies again in the phase 3 setting, one in the post-chemotherapy setting and one in the pre-chemotherapy setting. And they randomized patients to either abiraterone with prednisone or prednisone alone. And it's important to realize that prednisone in this setting is actually required to minimize some of the side effects. When you inhibit the hydroxylase, you get some upregulation of cortisone, which can lead to swelling and electrolyte abnormalities. And so basically, the prednisone helps mitigate those side effects. So it's not just an artifact of clinical trial design, as it is with docetaxel, which I'll come to, but that's actually the role of prednisone here. And the end result of this study was, again, about a 4-month improvement in survival. You really can't compare these numbers across studies. I think all we know is that in this study, this treatment improved survival, and this also led to FDA approval. As we saw with enzalutamide, it delayed time to PSA progression by about 4 months, and we see that the majority of patients had other responses by imaging or PSA relative to placebo. And again, so there were other readouts of success here, but really survival was paramount, and that's what led to the approval. In the chemo-naïve population, so this is the second phase 3 study, patients were randomized again, prednisone in the control group, essentially, or abiraterone plus prednisone. And you see here there was a median survival of 33.4 versus 23.4 months. Incidentally, this was approved before enzalutamide, so that could explain why the survival signal was preserved a little bit more. A lot of the enzalutamide patients probably got abiraterone at some point. So that brings us to our list of toxicities with abiraterone. Some of this is partially because of the prednisone that goes along with it. There are some derm complications, hyperglycemia. Because of those cortisol effects, there can be edema and hypertension. So really, it's a side effect profile, not because I have any real affection for enzalutamide beyond it, but it's a side effect profile, which is why I favor enzalutamide in this frontline setting over abiraterone. And that actually becomes very important when we move forward and realize new data that's come out in just the last few years, and that is highlighting the fact that the mechanisms of resistance for abiraterone and enzalutamide overlap. And so there's cross-resistance to these two therapies. And therefore, you might not be able to order two agents from the first course because they may not work well sequentially. So probably what's going to happen is you'll use one and you get a diminished benefit, if at all, from the second. And I'll go over that data in a second. But the reason why I favor enzalutamide is because if one therapy is going to work for 2 years and the other therapy is going to work for 3 months, it's probably better if that patient's not on prednisone for 2 years, and if that, and also the other side effects. Because of the data I'm about to share with you, other countries like Australia and Canada will actually only pay, their government health care only pays for enzalutamide or abiraterone because the data suggests that response rates to the other treatments are 20% or less. So what is that related to? Well, it's related to what has been highlighted in this New England Journal article here, but it's probably a broader phenomenon, and that is the fact that there are what are called androgen receptor splice variants. So I mentioned earlier one of the mechanisms by which the prostate cancer can resist treatment is by basically altering the androgen receptor and basically having an androgen receptor pathway that has no receptor. So that's a constituently active pathway that in the past at some point relied on testosterone to bind to the receptor that then led to intracellular cascade that led to cellular proliferation. But these variant pathways often have a receptor or no ligand binding domain, and so they're constitutively active in the absence of any androgens. And what Dr. Antonirakis and his group at Johns Hopkins demonstrated was that in patients who had previous abiraterone, as you can see with these arrows here, they were less likely to respond. I know I talked about PSA before, but it's a good readout here. They were less likely to respond and had rising PSAs after enzalutamide. Now realize if these patients didn't have previous abiraterone, As you can see with most of these patients, they would have likely had a much more pronounced anti-tumor effect. Similarly, patients who had previous enzalutamide didn't respond to abiraterone as well either. And what they found was that, in this paper at least, they focused on one of these variants called androgen receptor variant 7, or ARV7, and they found that there was a very strong correlation between the presence of this variant and a lack of response. So that goes back to the fact that there is basically clinical evidence that suggests that when you use these therapies sequentially, whichever one you use second probably has a response rate of about 20% as opposed to one that's much, much higher. So it seems like two very good therapies, but for the most part, we may not be able to use them sequentially. Now, there are studies going on to see if there's any benefit to use them together, and when that data is available with you, I'll be happy to fill you in. So then we talk about our second course. And so these are patients who have, as opposed to the first course where it was minimal to moderate symptoms, these are patients with moderate to substantial symptoms. And you'll see that the toxicity, especially with chemotherapy, is much higher. But in this case, it's worth it because essentially you get a better impact on symptoms. Enzalutamide and abiraterone did correlative studies that demonstrated that if you had moderate pain, you could get improvement. But there's no clear data that extensive pain gives you the improvement the way chemotherapy does. And also, if the disease is moving very quickly, it might be best to use chemotherapy. So people who think we shouldn't knock down trees or something like that because that's where we have the cure for cancer, they're not entirely off base. Docetaxel is derived from paclitaxel, which is a taxane-type therapy derived from the yew tree. And so maybe just don't tear down as many rainforests, I guess, is my little plug on that. But it's important to realize that taxanes were thought to work by, inhibiting microtubule assembly, which was thought to basically have an important role in mitosis. And if you have a lot of cellular proliferation from cancer growth, you have a lot of mitosis. And therefore, if we thought that if you're not letting the microtubules take part and you're freezing them, well, then the cancer cells can't proliferate. You have less mitosis. The reality is that perhaps something that's come across in the last decade to suggest that maybe it is really all about the androgen receptor in prostate cancer. Seems like we forgot about that for a while, but there is strong data that suggests that the microtubule impact is actually not on mitosis or proliferation, but think of microtubules as the train track by which the androgen receptor or androgen receptor variants travel from the cellular binding domain to the nucleus. And if you impair that, you basically lose that cellular intracellular cascade signaling. So again, it just all comes back to the androgen receptor, perhaps even with chemotherapy in prostate cancer. And that could explain why, with all the chemotherapies that are available, it's two taxanes that work in prostate cancer and no other therapies. So this was the study that was published in 2004. It was a landmark study. First time we demonstrated the ability to improve survival in advanced prostate cancer. And they investigated 2 doses with docetaxel, 1 weekly and 1 every 3 weeks. And basically what they did was they compared it to mitoxantrone and prednisone. I won't go into this data, but mitoxantrone and prednisone was approved in the 1990s by the FDA for prostate cancer treatment based on palliation. So no survival benefit, just improved symptoms. And here's the end result of the study. Basically, they found that 3 weekly docetaxel was better than 2 weekly, better than mitoxantrone. And basically that became the new standard of care. The median survivals were 18.9 months versus 16.4 months. So a couple things about this. These values have fluctuated over the years. Some studies before abiraterone and enzalutamide that were done suggested that this was over 20 months, but now that it's getting used later, it's coming down a little bit, and maybe it's closer to 10 to 15 months. But the one thing that I think principle that gets highlighted by this, I can't tell you how many patient groups I've talked at over the last decade where patients are like, see, that's why I'm never getting chemotherapy, because I'm not going to get chemotherapy and all the side effects that I show on the next slide for just a 2.5 month improvement in survival. And trust me, there's usually there's a lot of hand raising about that. And then I've had a lot of patients come to my clinic and they say, I'm not getting chemotherapy for this. And the wife's like, I want you to live, get your chemotherapy. And he's like, no, I'm not going to do it. Well, then you highlight the fact that there's an aspect of this trial which you should take into account when you assess clinical trials, and that's that there was a crossover. So patients on the mitoxantrone arm were able to cross over and get docetaxel at progression. So anytime you have a crossover in a clinical trial, your long-term outcomes like survival underestimate the benefit. And indeed, when you look back at historical trials with just mitoxantrone, the overall survival was closer to 10 months. So in that context, you realize that, yes, the patients initially randomized to mitoxantrone, lived 16.4 months, but a substantial number of them actually probably got docetaxel as well. So again, this is that post-treatment contamination aspect. So usually when I mention this in the office, the wife hits the husband, and then he kind of gets in trouble, and then he is more inclined to do chemotherapy. But just another, I think, important concept to understand about how to interpret clinical data. Now here is the toxicity, which I'm not going to minimize. It's chemotherapy, so there is side effects. But despite all this, I'll tell you that I've treated men in their 90s, and they still live productive lives. For the most part, these side effects are, I would say, for the most part, more annoying than life-altering for patients in the context of the fatigue and some of the risk of infections with neutropenia and things are really worse in the first week of a 3-week cycle, and then patients recover. We have trials at at our institution here where we've treated patients on and off, stopping for breaks and things for 50, 100 cycles every 3 weeks. So this is actually a reasonably tolerated therapy. In this trial, actually, they only gave it for 10 cycles, and that's still how a lot of people use it. But we have decided, based on our data here, that it's worthwhile to continue it as long as the patient's tolerating it. And despite this long list of infections, I think it is a worthwhile therapy when the disease burden is high, when they've progressed on earlier therapies, or when their symptoms are high. The big side effects, again, are the neutropenia, which can lead to infections, and then neuropathy, numbness and tingling that we see. A lot of the other things are more chronic and kind of slowly developing over time. So that brings us to the next item on our second course here, and that's radium-223. So you'll notice in prostate cancer, we don't just have a bunch of chemotherapies. We got anti-androgen therapies, immunotherapies, chemotherapies, and radium-223 is a infusional radiopharmaceutical therapy. And the way this trial was done, essentially, it's really not indicated for patients with visceral disease because radiopharmaceutical agent in this sense was targeting bone metastasis, as you'll see. But one of the tricky parts is, again, even though I like to brag about all these new therapies, and I've kind of already shown you caution about using PSA, people who treat prostate cancer really prefer therapies that make the PSA go down. That's the sad reality. And we're talking about Sipuleucel-T, and we're talking about radium. There is no immediate decline in PSA. So for that reason, it's still a little unclear how these therapies are being used. Older radiopharmaceuticals in prostate cancer, like strontium and samarium, were approved for palliation only. And so basically, that's kind of where radium is fit in as a replacement, because unlike those agents, this agent actually demonstrated a survival. Also advantage, which I'll show you in a second, but also unlike those agents, those were beta-emitting alpha particles, and radium-223 is a alpha-emitting radiopharmaceutical. I'm not going to pretend to understand the physics beyond what I'm showing you on this slide, but what I do understand is that alpha particles are heavier, so when they shoot off, the little chelated concoction that binds primarily to areas of high turnover in the bone, they don't shoot as far. And so what that means is if you have an area of prostate cancer in the bone, realizing that 90% of men with prostate cancer have bone mets, that's the most common place to go. When the alpha particle shoots off, it shoots off less than 100 micrometers. So I don't know what that is, but it's less than a beta particle. And because it's a smaller, basically, destruction radius, you're less likely to have a bystander effect of healthy hematologic cells like platelets and white cells and red cells. Those were the primary side effects that we saw with other radiopharmaceuticals that were used in prostate cancer. This one, with the lower destruction radius, with the alpha particle, we're seeing that a lot less. And this study was a little different than the other studies in that basically it allowed patients to be both pre and post chemotherapy, required them to not have any visceral disease, They couldn't have more than like 3 centimeters of lymph node disease. Visceral is not lymph node, just a reminder, that's always a point of confusion. And the results of this study, again, demonstrated no real dramatic short-term changes in PSA. Patients just live longer, which, again, is kind of what you want. So that, based on these findings, this agent was approved by the FDA for patients with metastatic castration-resistant prostate cancer. And so it is something we have. I have to say that I was at a meeting just last week in New York where we're still trying to figure out how to best use this therapy, perhaps in combinations or other disease populations. Importantly, though, I told you that this group of patients was more heterogeneous and that some had received chemotherapy and some had not. And the reality is the survival benefit was seen in both subgroups. So I think that that's an important thing to understand. The palliative benefit was a little less clear in the post-chemotherapy subgroup, but I don't think it was really powered for this, so I wouldn't overinterpret that. Generally speaking, when you have a positive trial, you can't pick it apart to find the data you want to believe in. So I think there's clear data that this works in both groups. Even though you have a minimal destructive radius, if you have a lot of lesions in the bone or near the bone marrow, you're going to have a lot of alpha particles flying around, so you are going to have some bystander effect with anemia, leukopenia, and thrombocytopenia, but they're not as extensive as what we saw in the previous agents like samarium and strontium. So it is actually a relatively tolerated agent, and for patients with substantial bone pain, it can bring relief. There was an article published in just Lancet Oncology this summer which said you could use this safely with enzalutamide and abiraterone, and in fact, when I recommend in patients who have already had chemotherapy and perhaps abiraterone or enzalutamide pre-chemo, I suggest patients often get radium with whatever treatment they didn't have before, if that makes sense. So in other words, if they had enzalutamide in their first course, maybe when they get to the radium standpoint, they can get it with abiraterone. So the third course is really docetaxel refractory patients. So these are patients who've already had chemotherapy. I've mentioned some data from the other agents where there is data which shows a survival benefit. The last agent I'll talk about today is called Cabazitaxel, and that is a taxane that differs from docetaxel based on 2 hydroxyl groups being different. Remember we talked about building a better mousetrap earlier? Well, you can be a little cynical. Maybe you thought Sanofi did this because they had docetaxel, which is going off patent, I think, next year. And so they thought they would come up with Cabazitaxel, which may be a little bit different and a little bit better. And maybe they can kind of maintain that patent space. Surprisingly, though, this trial came out of nowhere. Again, they took Cabazitaxel in patients who had already had docetaxel and gave them, they gave them Cabazitaxel or mitoxantrone. Honestly, when this data came out, everybody was surprised. This was not on anybody's radar screen. Despite a paltry kind of 2.5-month improvement in time to progression, there was a statistically significant improvement in survival. And so this was actually approved before abiraterone and enzalutamide, and it is available. Because of the side effects, namely, this trial saw about 5% of patients with infection-related mortality, and so that's been a constant thing that's plagued this treatment. So there's not a lot of use of this either. Again, these patients are pretty sick, and there's not a lot of enthusiasm after they progressed on docetaxel to give them another chemotherapy agent, although it has a role, and I think that you can find a way to use that on this menu that we've talked about. Now, there is updated data about Cabazitaxel from 2016 that's very important. I mentioned the drug company that developed this was maybe looking to preserve their patent space by the fact that docetaxel is going off patent in the near future. So they did a randomized upfront study with docetaxel in patients who were getting, with advanced prostate cancer, and then randomized them to their own drug, Cabazitaxel. That study did not show a difference. And so docetaxel is still the frontline agent. Also, they looked at dose because, again, there was some thought that having a lower dose might be less myelosuppressive, which is where the primary infection etiology came from. And they saw that 20 is just as good as 25. The reality is this was already being done in the community, so I don't think it's going to change things that much. The phase 3 trial did not have a lot of growth, did not mandate growth factor use, and that actually probably led to a safety signal that we're talking about. I've already talked about the use of these treatments after docetaxel. They all have data that shows overall survival benefit and can all be used. Ultimately, the goal is to really maximize quality of life for the patients while picking treatments that are relevant from this menu, and try to go through. That's kind of what I try to do in my clinic, is try to figure out where these patients are, how can they get the benefit of each of these therapies at the appropriate time point. I wish there was an easier way to say that we knew which to use when, but the field is doing trials to really evaluate that. Until then, hopefully, there was some logic and rationale in the way I laid that out. There are other opinions, but I think there are some slight variations, but that's, I think it's not a revolutionary thought process that I'm presenting here. I think a lot of people would agree. So I do still have a few minutes, and I want to actually talk about some things that are changing how we do prostate cancer in earlier stage disease. You guys have this slide in your handout. It's just something about cost. It always comes up. None of these drugs are cheap. A lot of people hang their hat on Provenge or Sipuleucel-T costing 35 grand a month. Well, enzalutamide, if you're on it for a year, costs a few times as much. These drugs are expensive, and that's something that's going to have to be addressed at some point, just because there are not limitless resources. But just another sense of one thing the menu didn't have was prices, and you hate going to a place that doesn't give you prices on the menu, so I thought I would at least give that here, and you can look at that a little bit more. I know that I said I would only talk about castration-resistant prostate cancer. I'm not going to try to confuse you too much, but I want to talk about a different population of patients now. This is patients who they're not castration resistant, so they're earlier stage patients. These are patients who walk in their doctor's office, don't know they have prostate cancer, and basically find out they have metastatic prostate cancer. It's castration sensitive, technically, because they haven't been exposed to androgen suppression. So these are either patients who 3 or 4 years ago had radiation and surgery, thought they were in good shape, and then came in and found out they had metastatic disease, or didn't know they had prostate cancer at all and showed up at their doctor's office with bone pain, and then they found out they had prostate cancer. So it's very different than the advanced populations I've talked to, where essentially they start off with local therapy and progress through to metastatic disease later on. These are patients who are showing up here, and from the get-go at this point, local therapy with radiation and surgery would not be curative. So interestingly, in 2007, they did a study that randomized patients to the standard of care at that time, which was androgen suppression therapy, versus 6 cycles of docetaxel, which again is approved in much later stage disease. I've already flashed through the data. You see that this is a remarkable, probably because of the timelines we're talking about, a 13.5-month improvement in survival over almost 5-year period. So that's a substantial change in how we manage early metastatic disease, where 2 years ago we would have only given them androgen suppression therapy. Now we found out that 6 months of docetaxel can improve that. I think this is having implications in how we reevaluate early stage disease. They're looking at ways to improve on this with some of the newer therapies, and perhaps seeing if we can bring curative measures to patients who are diagnosed with maybe only 1 or 2 bone lesions. That's something that is being increasingly explored on. I won't go over the subgroup analysis just in the interest of time, but I will tell you this was very well tolerated. And I would say that if 88% of men who tolerated this therapy were basically tolerated it well enough to get all 6 infusions, I think that speaks to its tolerability. But just in the interest of time, I'll skip over the slide you have on some of the controversy of treating low volume. My upshot is that it's a non-toxic regimen, so all people, regardless of the arbitrary volume designation, should get it. I want to thank you for your time today. I will say that just looking forward, because I know you guys, you are doing research, I still think there's a lot of room for improvement. As you know, none of these therapies are curative, so maybe taking some of these therapies earlier, minimal metastatic setting, and seeing if we can combine some of them to get cure. That's one of the points of emphasis. Better understandings of resistance mechanisms will hopefully improve our understanding of how to treat them. And then immunotherapy. I think Sipuleucel-T started. There hasn't been a lot of progress. We do a lot of immunotherapy here, and so we're trying to work with others to advance immunotherapy in prostate cancer, which has been left behind, I think, since Sipuleucel-T came about. So here's my email. Like I said, you're going to get a lot of, unfortunately, family, friends, and neighbors and stuff who have prostate cancer questions. Feel free to email me if anything comes up. You can follow me on Twitter if you're so inclined. I usually just tweet about prostate cancer or immunotherapy, I don't tweet about what I had for dinner last night, so that's enough of the menu analogy for me for now. So hopefully you guys all have an enjoyable dinner planned ahead and one great lecture coming up after this. So thank you for your attention. Yes. So the question I'll repeat just because I don't know if that gets heard, but I've said PSA isn't a great biomarker of response, yet I showed a couple slides where it shows a initial readout of responsiveness of the tumor. And I think the answer is, I think it does show some early benefit in terms of efficacy, but it doesn't show, it's not a good indicator for duration of response. So it tells us kind of the direction you're going in, but it's not the indicator of when you should switch therapies. And a lot of the phase 3 trials I showed you, basically all, with the exception of the docetaxel, did not use PSA progression as their primary progression criteria. They used radiographic progression. So my concern would be that if you stopped a therapy based on a 10, 20, 30% rise in PSA, you're actually shortchanging the patient because you're curtailing the potential clinical benefit of getting those treatments further. So I think in early studies, it's a good indicator of responsiveness or a response of a treatment. But I think in clinical management, radiographic or clinical parameters are much more important. It's a good question. It's still a point of confusion, yeah.
Do you have any sequencing data on the antigen receptor itself on these patients?
Yeah, so a lot of people are doing that now. That's actually where, so the question was, do we have sequencing data on the androgen receptor? And yeah, that's where a lot of this androgen receptor splice variant information came from. But that's a very popular correlative study with many trials that are ongoing, which is looking at the evolution of that resistance mechanism by sequencing the AR. Very good. Well, thanks for all staying awake. I appreciate you coming, and I know you got one more lecture to go, so I'll get out of the way.
Hold on. Not so fast.
Trying to run. Thank you.
Okay, so I'm working on setting up the tumor board rotations and visiting the core facilities. I'll probably have something for you at the start of next week, and then I'll be emailing everyone, and you can sign up for the activities that you'd like. So our next speaker is from the surgery branch, Stephanie Goff. She's a staff clinician. She got her general surgery residency at Columbia University, followed by an oncology fellowship at Dana-Farber and Brigham. And her title is about immune checkpoint blockade.
Okay. Thank you. All right, so we're going to talk about immune checkpoint blockade. And you might be wondering, why is a surgeon talking about immune checkpoint blockade? And we'll get into that in a little bit. But it started with who's the best to look at a tumor, and that's the one that can take it out. So that's kind of the history of why the surgery branch got into immunotherapy. And more specifically, we'll go into immune checkpoint blockade. It's a hot topic, and I'm sure any of you that are following cancer or cancer literature know a little bit about it. So what are we going to talk about? We're going to talk about the basics of immunotherapy. We're going to talk about the mechanism of action of checkpoint blockade, some of the early clinical experiences that we had here and how we discovered immune-related adverse events. We're going to talk about checkpoint blockade in melanoma. Those are 3 of the drugs that we're going to talk about. One of the challenges of checkpoint blockade is pronouncing the medications. So it's ipilimumab, nivolumab, and pembrolizumab. We're then going to talk about checkpoint blockade in other cancers and look at what the experimental questions are that are being answered today. Now, the handouts that you have are almost exactly the slides that you're going to see, but I have made a couple changes and added a couple of late-breaking sort of things in there. So we often talk about oncology, and before 5 years ago, people would have shown you this, and it would have only been a 3-pillared portico, but now we've got 4. The first one and the oldest is surgery. The very first known operation for cancer was done in ancient Egypt, and it was actually documented on scrolls that they've seen in hieroglyphics. It was taking out a breast cancer. Radiation came about in the late 1800s, early 1900s. Chemotherapy came about as a result of work done both here at the NCI and at Dana-Farber. And now immunotherapy has joined as one of the 4 pillars of how to treat patients with cancer today. So there are a couple different ways that cancer immunotherapy works. The first and most broad is a non-specific stimulation of immune reactions. So cells that you already have within your body. Can we stimulate them to go after your cancer? Press on the gas, to use a car metaphor. Or they already have the gas pressed, but there's a brake involved, and so you have to take off the brake, and that's inhibiting the regulatory factors, and that's checkpoint blockade. Another way is to try to teach the T cells that you already have how to find your tumor, and that's what cancer vaccines are trying to do. And then a lot of what we do now in the surgery branch, and many of you may have seen Dr. Rosenberg's work with this, is to actually work on T cells outside the body and then give them back, and that's adoptive immunotherapy. But what we're going to talk about today is the inhibition of regulatory factors, or checkpoint blockade. So these are the cells of the immune system for those of you that aren't primarily immunologists. Our marrow is responsible for making up all the cells that are in our blood compartment. And some of those are blood cells, red cells. Some of those are our platelets, which help us clot. But the vast majority of the cells that get made are part of our myelocyte or granulocyte lineage. And the ones that we're going to focus on for adaptive immunity are the ones that you see here. So we've got T cells, which can basically be broken down into CD4 cells, which are called helper cells, and CD8 cells, which are very generically called killer cells. Now, there are different kinds of all of those, but that's sort of where you need to be at the beginning. And then B cells, which make our antibodies. There's some other non-specific things that help us both fight sort of baseline infections, what we call innate immunity, things that can happen really fast, things that go into play when you get stuck with a splinter, not things that go into play when you catch a flu. So when you catch a flu, this side gets activated. When you get a splinter, this side goes to work. We're going to talk more about this because it's slower, but it's the one that's a little bit more easy to educate. And checkpoint blockade primarily affects T cells. So how's a T cell born? When these T cells come out of your marrow, they go to the thymus. That's how they got their name, T cell, because they're differentiated in the thymus. And they go through a process where they're exposed to an antigen. They're exposed to something that may make them turn on. And a couple things can happen. Either they don't see any antigen at all, and then your body realizes that that combination of genes isn't effective for that person. That T cell goes on to die because it hasn't seen an antigen. It's not needed. That's what we call anergy. Or it gets hit with a signal that's so strong, say, an antigen that's on every single cell in your body. Say if you're blood type A, then it's seeing protein A, and your thymus knows you don't want to go around destroying blood cells that have A on them because then you wouldn't have any blood cells left. That's called negative selection. So it sees such a strong stimulus that it kills that T cell to prevent it from going out and causing harm. But then there's that middle level where it gets just enough stimulation to get turned on, but not so much to get turned on too much, and that's called positive selection. Those are the T cells that we end up living with. And those are the T cells that make up the repertoire. You can have, most people would say now that you have a repertoire of about 10 to the 7th different types of T cell receptors in your body at any one time. Because you have about 10 to the 12 T cells in your body. So T cell activation happens in 3 different steps. The first is what tells the T cell that it's found the right target, and that's the specificity. So what has to happen there is that an antigen, which is some abnormal protein in your body, or an abnormal protein that's come in on a virus, has to get digested by the cell. And it gets put out onto the surface of the cell in these components called MHC. Now, we could talk exactly about what MHC is, but you want to think of it as sort of a white blood cell type, just like your red blood cell type. You inherit it from your parents. It makes the shape of the little pocket that these little antigens can sit in. So you have to have the right combination of MHC and antigen for this T cell, which is going to have a very specific protein shape in the folding here to actually see it. And that's called signal 1. So your lock and your key have to fit together or else nothing else matters. So it can either happen this way in a CD8 type phenomenon, or it goes through a slightly different processing for CD4. but the TCR has to find its antigen. That specificity has to be there in the beginning. So that's signal 1. The next signal is what tells that T cell either to turn on or turn off. So this is the lock and key that we talked about here. So once that antigen fits in here, then the cell's going to look for one of these other things to click with. If it clicks with CD28, it gets turned on, and all these things start to happen. Cells grow, they develop effector function, they survive, they thrive, they proliferate. If it clicks to one of these other inhibitory molecules, CTLA4, PD1, there are a lot of pathways we still don't understand, but it tends to shut the T cell off. This is called signal 2, or what we call our co-stimulatory molecules. Signal 3, as you might imagine, now you've got a lock and a key that have been put together. It's clicked together because it's going to work. But what kind of environment is it living in? What kind of cell is it going to turn into? Well, when you're talking about a helper cell, it can turn into a bunch of different helper cells. It can turn into type 1, type 2, Th17, which we haven't fully elucidated what that does yet, and a regulatory cell. All these things help to keep things in checks and balances, right? You want to have a vigorous immune system to attack anything that comes in, but you also want it not to destroy yourself. If you think about some autoimmune diseases, type 1 diabetes, the body is attacking the cells in the pancreas that make insulin. Ulcerative colitis, the body is attacking cells that live in the colon. It's because there's been a dysregulation of this checks and balances. So signal 3 is the environment that the cells are living in, and it helps develop these cells into the kind of cell they're going to be. But what we're really interested in from a cancer immunotherapy standpoint is the role of these signal 2 checkpoints. So these checkpoints are what help us promote self-tolerance. If you have a T cell that knows how to recognize your thyroid, if it's got a break on it, that's fine. It's not going to destroy your thyroid. If that thyroid cell turns into thyroid cancer, we want to find a way to take that break off so that it can learn how to go after it. Same with melanoma. If your T cells can recognize your skin, we don't want it to destroy your skin on a regular, everyday basis. That's called vitiligo when you see people with white patches. But if that skin cell turns into a melanoma, we certainly want the T cell to be able to go after it. We want to be able to lift that break. So what we're trying to do is break tolerance. So when your body sees antigen, it's usually in the things that you've grown up knowing about: lymph nodes, tonsils, all the places that get swollen when you get a cold. Peyer's patches are very specific areas of immune cells that live in the gut. Mucosa-associated lymphoid tissue also lives in the lining of the stomach. These immune checkpoints can limit the collateral damage. So say that splinter comes in and it starts to affect your finger, and all the cells that you need go there to try to get rid of that splinter to prevent any bacteria from coming in. You want that to shut down at some point so that it doesn't just inflame and inflame and inflame and eventually your whole finger turns red. You want it to get just red enough to get rid of the problem and then go away. And that's what the second part of the checkpoints can do. So these are two different ways that we can try to break this tolerance to self-antigen and make our bodies figure out that the cancer doesn't belong there. So the first way we do this is with CTLA4. Now this was work done by Jim Allison, who's gotten a lot of press recently, most deservedly so, on his understanding of CTLA4 and its role as a checkpoint blockade. So the cell you see in purple is a T cell. This is a T cell that has survived coming out of the thymus. It has a particular TCR, a particular lock that needs a particular key. And when it finds that antigen, what's happening is that it's actually putting CTLA4 on the surface. So then this cell, rather than finding this T cell and turning it on with CD28, it actually turns it off by hitting CTLA4. And so something that might have been working gets shut down and gives it a negative signal. And so all the things that are happening in the nucleus to make this cell become an effector cell get stopped. So it has a dampening effect on any sort of downstream processing that happens. And these cells called T regulatory cells that help keep everything in check, they always have CTLA4 on the surface. Second way that we can engage this is when that T cell leaves that lymph node, leaves that area where it first sees its antigen, and it goes out to the tumor or out to the tissue. The tissue itself can put up the ligand called PDL1 or PDL2, and that engages PD-1, which again is a negative signal to the T cell. So if we can find a way to block this interaction, we could stop it from shutting down this T cell. Ordinarily, this is what you want. This is what keeps the immune response from destroying your entire finger when you get a splinter. But when that's going after a cancer, we don't want it to stop till the cancer's gone. So how does this work in cancer? Well, there are some cancers, particularly some brain tumors, that just part of the DNA changes that have made them a cancer, they actually upregulate PD-L1. So there's more PD-L1 on the surface of that cell present to block any sort of immune response, called constitutive oncogenic signaling. Part of what makes it a cancer gives it that PD-L1. Certain cells in Hodgkin's lymphoma, Reed-Sternberg, do the same thing. The other thing that can happen is when we get an actual response, when that T cell finds a tumor and knows how to kill it and starts killing it, the cell as a survival mechanism actually starts putting PD-L1 on the surface to try to stop it. So even if the cell doesn't have any PD-L1 on it to begin with, once the T cell engages it and starts to kill it and starts to build that tumor microenvironment, it and other cells around it will start to upregulate PD-L1 in response to the presence of interferon gamma, and will start to shut down those T cells. So if we can find a way to block both of these, we might have a way to enhance a cancer response. So where did we start with this? So we decided to start with tumors that were known to respond to other forms of immunotherapy. Melanoma is a rare cancer, but can be a deadly one when it gets advanced. There's only about 10,000 deaths per year in the United States. What's important to remember, because all of you will probably know someone, if not yourself, that has had a melanoma, 95% of all melanoma is cured with the first incision. It's only when it gets to metastatic that it becomes so deadly, and that's a very, very small percentage. So if you have a mole that you're worried about, don't panic, just go see your dermatologist. When it gets to be metastatic, up until recently, you only had about a 16% chance of surviving 5 years. One of the first drugs that was found that could cure, and we don't use that word often in cancer, but could cure patients, was interleukin-2. And that's that first kind of drug where I said you step on the gas and you try to rev up all the immune cells in the body. When you give that drug to patients with metastatic melanoma, 4% of them will have all of their cancer go away and stay away. We have follow-up on this 20, 30, 40 years. These patients are still alive. Kidney cancer, surprisingly, is another one that responds to immunotherapy. This is a little bit more common than melanoma, with just as dismal survival rate. It also has cure, durable cure, 10, 15, 20-year follow-up in about 7% of patients. So these were our first targets. We actually did these studies at the surgery branch back in 2001 when it was first in human. So anti-CTLA-4, or ipilimumab, which is now known as Yervoy, began as a phase 1 trial. And we treated these patients with a monoclonal antibody plus a peptide vaccine. We had 14 patients, which is a very small study for phase 1, because you're just wanting to see that you can give it safely. To our surprise, there were 3 responses. 2 of them had all of their disease go away. 1 had a partial response. But what was interesting was that we started seeing toxicity. Bad skin disease, colon disease, liver disease, and attacking the pituitary gland. So what you see here in figure A and B, this is a patient, for those of you not used to looking at CAT scans, these are the lungs. The patient is laying flat with the feet coming toward you and the head going back into the screen. What shows up on the left side of the screen is actually the right side. What shows up on the right side of the screen is actually the left side. So this is a tumor present in the periphery of the lung, and you can see from the shape of the heart and everything else that we're in sort of the same slice, and that tumor is now completely gone. But what we were seeing, this is skin, and we're seeing an influx of T cells and destruction of this cortical layer between the skin. All these white areas in the skin shouldn't be there. We're seeing the same in colon. This is colon with a lot of inflammation, and this is a specific stain for CD8 cells. So you've got this influx of lymphocytes into an area where there shouldn't be that many. And this is a liver biopsy, again, with just an influx of lymphocytes. So the way that you test any sort of chemotherapy that we had known up until this point was that if you get toxicities in your phase 1 in your safety study, you stop and you go back and you dose reduce. And so we used that same model, going from 3 down to 1 milligram per kilogram. What we found, though, was that unlike chemotherapy toxicities, if these patients were getting these other sort of side effects, it meant that their immune system was getting turned on. And so the chance of having a response was actually elevated if they had one of these side effects. So just for terminology here, AE is adverse event, grade 3 drastically affects patient's lifestyle, goes from 1 to 5. And in our patients with melanoma, if you had a grade 3 or higher AE, you had a 36% chance of responding. Whereas if you didn't, you only had a 5% chance. It was even more striking in kidney cancer. If you had a greater than grade 3 AE, you had a 20, all of the responders showed some sort of side effect. So we realized we had to change the paradigm. It wasn't get a toxicity dose reduce, just like you do for every sort of chemotherapy. You actually wanted to push the toxicities as far as you can, as long as you didn't hurt the patient in a lasting way. So we started a phase 2 where we actually would up the dose in our patients, starting with 3, going to 5, going to 9. And what you can see here is, again, the correlation held. If you had no immune-related adverse event, you had a very small chance of responding. If you had a grade 3, you had a slightly higher. But even if you had a grade 1, 2, you still had a slightly better chance. The problem was enterocolitis started to become much more of a problem, 18 and 28%. So enterocolitis is that the immune cells started attacking the colon to the point where it actually perforated the colon in a few patients, and one patient did die from a colon perforation. So then we had to develop an algorithm for dealing with these immune responses to get our patients through safely, and we found that giving steroids would slow down the adverse events, but it wouldn't stop them from having a cancer response. So what we did is we wanted to see how long this would last. Was this something durable, similar to IL-2? Well, we developed algorithms for managing the immune-related adverse events. Obviously, when you get a study to this point here at the NCI, it then goes out into the world. And so we had to develop algorithms for helping clinicians across the country work with this as it went into phase 2 and phase 3 studies. But what it did show when we looked at the long term, this is 7, 9 years. This is what we call the tail of the curve. Most studies of chemotherapies, this line eventually goes down to 0, particularly when you get to 5, 6, 7 years. What we were seeing, though, is this tail of the curve. There are people getting long-term benefit from these drugs. So just to remind you, this is the T cell. This is the tumor cell. This is that lock and key phenomenon. That's the first thing that has to happen before any of the rest of this makes sense. The antigen has to be in the right MHC and presented to the T cell receptor. That lock and key has to fit. And then you want it to have this positive signal. So you can use these antibodies, nivolumab or pembrolizumab, which are anti-PD-1, or ipilimumab, which we've just talked about a little bit, to try to block CTLA-4. So let's go into a little bit about how these drugs got approved. So ipilimumab is the one that we studied here in phase 1 and phase 2. It then went on to be a national trial run by the folks at Dana-Farber. And they were able to test it in 540 patients. And what they found was that 38 patients had some sort of response. 3 of them had their disease go completely away. And again, when you look at overall survival, here the data is mature to about, let's see, where's our median? Probably about 3 years. You can see a tail of the curve. There are people that are surviving, 3-year survival in the 20% range. So it got approved for metastatic melanoma, for which there were far too few drugs in March of 2011. It was the first monoclonal antibody developed for metastatic melanoma. They just recently updated their survival data, and again, now that we've got, 7, 8, 9, 10 years worth of data, you're still seeing this tail of the curve. You've got patients who at one point had a 16% chance of surviving at 5 years, and now you've got 20% of them still alive at 10 years. So tail of the curve is very important when talking about immunotherapy, and it's what distinguishes it from most chemotherapies. So it's durable, but it's for a small number of patients. Doesn't always work. Tremelimumab is a different form of the anti-CTLA-4 antibody. It uses a different monoclonal antibody, and it did not have a successful trial when it was tested against dacarbazine temozolomide, which is a chemotherapy sometimes used for metastatic melanoma. And what you can see is the survival curves completely overlap. So this drug didn't make it. Not every drug does. But because we don't know a lot about exactly how all of this can work in combination with other things, it's now being studied in trials. Particularly, we have one here at the NCI that the TGIB branch is doing, where they irradiate a tumor hoping to release new antigens and then combine it with tremelimumab, and that's ongoing. Nivolumab is another drug. Started a lot of the preclinical work was done by Dr. Topalian before she left the branch to go to Johns Hopkins, and started with a phase 1 dose escalation. So when you have the resources and the expertise to do a phase 1 in multiple different cohorts, which they did at Johns Hopkins, they enrolled, close to 250 patients here in various different diseases: melanoma, non-small cell lung cancer, kidney cancer, castrate-resistant prostate cancer, and colorectal cancer. And these spider plots show you when you measure all the tumors that these patients have and you watch it over time, what you want is to see all these go down. And so what they saw was that in melanoma, they saw a 28% response rate. Again, in kidney cancer, also 27% response rate, which was validating, but not all that surprising. What was surprising was non-small cell lung cancer showed up with an 18%. And this is what we call finding a signal. So it's phase 1. You're not doing it to try to determine a response rate. You're looking to make sure that the drug is safe, but you get these tickles, these ideas that it might work. Unfortunately, what it also showed that it didn't show any signal in prostate or colorectal cancer. And when we talk about, prostate cancers being left behind by immunotherapy, a lot of this early work is the reason why. But they were still developing grade 3/4 toxicities in 6% of patients. What you're looking at here again is CAT scans. Now this is a patient with non-small cell lung cancer. Before treatment, you can see this smudge here and this smudge down here. What can happen with these drugs is when the immune cells actually go into the cancer, they can make it swell. And if you didn't know, if this were a regular standard chemotherapy and you saw this growth of these tumors, you'd say, well, not working, right? The tumors are bigger here at 2 months. But without any additional treatment, look what happened at 4 months. Now they're gone. So this is something, we had to learn how to do immunotherapy as we were doing this because it's different than chemotherapy. Because that signal was so strong for melanoma, they went on to do a study specifically in melanoma. Because ipilimumab had now been approved, all these patients had to have already been through ipilimumab therapy. And now you're looking at nivolumab versus chemotherapy of choice. The kind of graph that you're looking at here takes the best response that the patient has. It's called a waterfall plot. And for this to be successful, you want to see more below the line than you do above the line. So a patient having a decrease in tumor are the lines that you're seeing here. And what we saw was that with nivolumab, close to 32% had an objective response. 4 of them had their cancer go away completely. Because of this, it was approved for ipilimumab refractory melanoma in December of 2014. So what did that mean? It meant that any patient that wanted to get nivolumab had to have already been through ipilimumab, which is great, but ipilimumab has some toxicities. So can we test it perhaps in patients who haven't been through ipilimumab? So this study then tested patients with untreated metastatic disease. because there were drugs that had come out at the time to target patients who had BRAF mutations, the FDA insisted that these patients had to be wild-type BRAF and not eligible for those other drugs. And the test again was nivolumab versus dacarbazine. And here you can see it's very rare, very, very rare in cancer to see survival curves split like this. This is kind of a research dream to see something like this, then you know that you've got something that's really going to work. Now, what I will caution you on is the length of time here. This is only 18 months. This isn't very mature data, but striking. So at 18 months, 70% of the patients who were treated with nivolumab were still alive. 40% of them had an objective response. 16 of them had their disease go completely away. They recently updated this just this last year in Louisiana at the AACR. And now you're looking at 5, 6, 7 year. And again, it's not as impressive as that 70%, but look, 5-year overall survival, we've now doubled from what it historically was up to 34%, all patients. Again, tail of the curve. Pembrolizumab is another form of anti-PD-1, and it went through the same trials that nivolumab did. First, it had to show its ability to affect a response in patients who had already been through ipilimumab. They treated 157 patients. You can see the response rate that we saw there, with a low rate of grade 3-4 adverse events. But again, you'll note that the time course is very short. Despite that, however, it did get approval in September of 2014. They went on again just to look at 2 different doses, and it showed that it didn't matter which dose of pembrolizumab you used, the effect was still the same. And so the dose now is 2 milligrams per kilogram rather than 10 milligrams per kilogram. When you start talking about the cost of these drugs, that's a huge change for the better for the patients. But then they wanted to see, well, should we do this as first line? Now, if you remember when I showed you ipilimumab, it was testing against chemo of choice. Pembrolizumab actually went head-to-head with ipilimumab. So they did 2 different dosing regimens versus ipilimumab in a 1-to-1-to-1 fashion and treated 834 patients. And you can see here the response rates, despite the dosing schedule, didn't matter. You could get about a 33 to 34% response rate with pembrolizumab with a substantial number of complete responses. Ipilimumab stayed exactly where we always thought it was, about a 12 to 15% response rate with some CRs. And the survival curves, though not as dramatic as with dacarbazine, clearly split. The difference being the grade 3 adverse events were lower for pembrolizumab and definitely lower in the colitis range. The colitis turned out to be, for ipilimumab, the most devastating of the toxicities. So they've updated this most recently in JAMA in 2016. These are the same patients. And if you look, this is all pembrolizumab now. They've taken out the ipilimumab arm. We're here at 2 years, 60% survival. So in checkpoint modulation, the 2 approved antibodies interfere with different receptor ligand complexes. Could we combine them, perhaps, to get better responses or survival? And that's exactly what happened next. So they looked at the combination therapy for melanoma. And what they actually tested, it was, again, in a 1-to-1-to-1 fashion, single agent nivolumab, nivolumab plus ipilimumab, and single agent ipilimumab. 945 patients. They defined PD-L1 positivity as greater than 5%, which is just a detail that's important for people that look at this, but we'll talk about that in a little bit more later. What they found was that the combination could respond, 58% of patients could respond to combination therapy versus 44% of patients to single agent nivolumab therapy and only 19% in ipilimumab. But look at the grade 3/4 adverse events. When you combine the two, the side effects skyrocket. And so while it can have a phenomenal response rate, and we think those are going to be durable, although the data is not yet mature, you pay the price with a lot of toxicities. And so it's still being debated in medical oncology circles as to whether patients should be treated with single agent, PD-1, or combination. The reason for that sort of struggle is that we don't always know the PD-L1 status of our patients. And if you're already PD-L1 positive, you get a pretty good response rate to just nivolumab alone without buying all the extra toxicities of the combination therapy. Whereas if you're PD-L1 unknown or negative, you have a very lower rate of responding to single agent nivolumab, but that gets rescued by the addition of ipilimumab. So that's why there's still some equipoise out in the melanoma community. So they have updated their results. This is now not overall survival, but progression-free survival, with the orange line being the combination therapy, the blue line being single agent nivolumab, the green line being ipilimumab. And you can see at 18 months, 46% of the patients have not yet progressed on combination therapy. They have not updated their overall survival because they claim it's still too immature, and I agree. So we'll see probably updated information from them at ASCO 2017, which will be next June. But the combination has been approved for the use in patients with metastatic melanoma as of January 2016. So why melanoma? If you look at the paper put out by Lawrence et al., they studied the number of non-synonymous mutations within different tumor types, and melanoma has the most. We think it might be a combination of these mutated tumor antigens that simply a lottery ticket. The more mutations you have, the more likely you are to have a T cell that can recognize your cancer, and the more likely these drugs are to then ignite those T cells to go after it. But what about other highly mutated tumors? So non-small cell lung cancer by far dwarfs melanoma as far as its impact on American society, with close to 160,000 deaths per year. If you develop metastatic disease with non-small cell lung cancer, you only have a 2% chance of surviving 5 years. And there is a correlation between smoking and the number of mutations. Bladder cancer, about 16,000 deaths per year, again, highly lethal once metastatic, so lethal, in fact, that they don't even put together 5-year overall survival statistics for it because the numbers are too small. And tumors with mismatch repair deficiency, which is an inability to fix DNA problems during daughter cell replication, a syndrome known as Lynch syndrome, and problems with these 4 mismatch repair genes. These tumors all have high numbers of somatic mutations and might be candidates for this kind of therapy. So nivolumab, again an anti-PD-1 agent, was tried in non-small cell lung cancer. And you can see the waterfall plot that we've discussed before. You've got a fair number of patients here that are still alive and who had their tumors go away. This is specifically for the squamous cell subset of non-small cell lung cancer. They tested nivolumab against docetaxel, which is a chemotherapy. And again, you're seeing one of those beautiful splits like we haven't seen in chemotherapy for a long time, with response rates of 20%. Based on this data, the FDA did approve nivolumab for refractory squamous non-small cell lung cancer in March of 2015. The other variety, non-squamous, again, not quite as dramatic a split as the other, but showing a clear signal with 19% response. And based on this, that approval was expanded to include non-squamous non-small cell lung cancer. Pembrolizumab, again, the other anti-PD-1 drug. This one's, the first one is known as Opdivo. You might have seen their commercials on TV. This one is known as Keytruda. I don't know that they have as much of a TV presence as Opdivo does right now. But they were doing a bigger study called Keynote-1, but they did treat close to 500 patients with non-small cell lung cancer, and they saw an objective response of 20%. When you looked at patients who were smokers, who potentially had a higher degree of mutations because of the carcinogens that were bathing their epithelium, they had a higher response rate at 22.5%. However, it also engaged T cells that attacked normal lung tissue to an extent that it actually included one fatality. However, based on this, the FDA did grant approval of pembrolizumab for advanced non-small cell lung cancer in October of last year. Bladder cancer, also highly mutated because of the carcinogens that we ingest and come in contact with on a daily basis end up getting filtered by our kidneys and sit in our bladders. And so bladder cancer tends to have a fair number of mutations. MPDL3280A, which luckily got a name recently, atezolizumab, I don't know how lucky we are, that's a difficult one to say, is an anti-PD-L1. So it blocks the other side of that receptor ligand complex. They treated all comers, but they did show that patients that had more than 5% of PD-L1 had a 43% response rate. So the colors you see here, the green, those in the green are the ones that had high expression of PD-L1 on their surface, and the ones in red were the ones that did not. And while you can see there are some greens that did not have a good response, and there's a single red that did have a good response, by far most of the greens are over here and most of the yellow reds are over here. This was updated recently, looking at all patients, and you've got here a 1-year survival of about 40%, which is almost unprecedented for metastatic bladder cancer. Based on this, this drug, which is the first against this target, anti-PD-L1, atezolizumab, which I think is going to get a much easier name called Tequin or something similar to that, was approved for urothelial cancer in just a few months ago in May. Pembrolizumab, the other PD-1 agent, was also tested in urothelial cancer. And you can see the very small numbers here, only 29 patients that were evaluable, but it had a response rate of about 30%. Nivolumab, also tested, 78 patients, only 29 of whom were evaluable. This is a study in the very early ages. We try not to say that patients are evaluable until we've had at least 6 months to follow them. So at the time that this was presented at ASCO, only 29 patients were evaluable, but they had a response rate of 24%. So what about those mismatch repair deficient cancers, those ones that have many, many thousands of mutations? They did 3 parallel cohorts. So mismatch repair and Lynch syndrome is most well discussed in patients with colorectal cancer, but those patients can also form other cancers, endometrial among them. So they looked at your standard colorectal cancers, what we call MMR proficient, and then deficient, and then other cancers that are also deficient. And what you can see is that those with deficient, meaning large numbers of mutations, are pictured in blue or black, and those with the ability to repair their DNA correctly are in red. And you can see that the reds kind of all had their tumors grow, with the exception of these, and the blues and blacks almost all had their tumors go down. So this really added to the working hypothesis that it's these neoantigens or somatic mutations that are really driving the ability of these drugs to work. And what they did was actually look at this. So H&E just gives you a look at the structure of the tumor. And what we're looking at, T is tumor, N is normal. So you're looking at the interface where a cancer and the normal surrounding tissue interact. This is a proficient colorectal cancer, one that can repair its DNA, does not have a lot of mutations. This is a deficient colorectal cancer who cannot repair DNA problems, not correct their DNA problems, and has a large number of mutations. And you can see here, not only is there a lot of PD-L1 on the surface, these are biopsies taken, by the way, pre-treatment. This is before any checkpoint blockade has been given. So this is the natural living state of these tumors. They have a lot of PD-L1 on the surface between the tumor and the normal. And all these little brown dots here are CD8 T cells. So there's an infiltration of them at the interface. And you can see here very few of those CD8 cells infiltrating. Particularly here, you can see this is blown up. Very few of them, and very little PD-L1 staining. So checkpoint blockade, we've talked about highly mutated tumors, we've talked about melanoma, we've talked about non-small cell lung cancer, bladder cancer, and tumors with mismatch repair deficiency. Well, what about use in some other tumors? So renal cell we know can respond to immunotherapy. It can develop a cure rate to IL-2. Hodgkin's lymphoma, Reed-Sternberg cells are one of those that oncogenically upregulate PD-L1. And head and neck squamous cell cancers, in the context of HPV, can have a lot of mutations. So has it been tested in those? And of course the answer is yes. So nivolumab for kidney cancer, they tested it versus everolimus, which is an mTOR inhibitor. And what they found was that they could get an objective response in 25% of patients with nivolumab and an increase in median survival. Based on this, it did receive FDA approval in November of last year. Hodgkin's lymphoma, you've seen enough of these waterfall plots now to kind of understand how rare this is, how many of these lines go down. 66% objective responses, with 7 patients who had all of their lymphoma go away. These aren't your run-of-the-mill patients with Hodgkin's lymphoma. These are patients who have already undergone stem cell transplant and their disease has come back, and they've already undergone treatment with brentuximab and their disease has come back. So these are very refractory patients with very limited options, and you're able to create 7 complete remissions. As you might expect, on the basis of this strong data, it was approved for refractory Hodgkin's lymphoma in May of this year. In head and neck squamous cell cancer, now this they did not require a look at the tissue to see how much PD-L1 was there, but they were able to get a response rate in the 18% range overall. Those patients who were HPV positive had a slightly higher response rate. You can see the overall survival here. At 18 months, about 30% still alive. It has been approved for recurrent or metastatic head and neck squamous cancer as of last month. So blocking the PD-1, PD-L1 pathway, we've talked about a lot of different tumor types and a lot of different drugs that have targeted this. As of this weekend, when I finish these are all the ones that are FDA approved. The others are all being evaluated for possible approval, but these are the ones that have been approved as of this moment. But what about other cancers? So in breast cancer, I'll go through these fairly quickly. You can see response rate in about 19%, but there's some controversy as to how many triple-negative breast cancers will have PD-L1. This study claimed 60%. Another study out of MD Anderson claimed only 20%. And a lot of it has to do with the antibodies that are used for the immunohistochemistry. When looking at now not triple-negative breast cancers, but breast cancers that have ER-positive HER2-negative tumors, they were able to get partial responses in 3 patients. Again, this is all very small numbers. Gastric cancer, small numbers, but a very lethal disease, 22% objective response rate. Just to give you an idea of how active this field is, these are just some of the abstracts that were presented at ASCO 2016 this year. So you're looking at tumors ranging from sarcoma to uterine leiomyosarcoma, small cell lung cancer, salivary gland cancer, cervical cancer, endometrial, esophageal, thyroid, gastric, adrenocortical, Merkel cell, ovarian, mesothelioma, urothelial cancer. There are others that combine these drugs with forms of radiation, that combine these drugs with vaccines that I haven't put on this list. You can see just the amount of work that's going into this. These 2 studies here are done by investigators here at the NCI. There's ongoing work here, in particular combining some of these monoclonal antibodies with vaccines and with radiation therapy. But you can see across a wide variety of cancers, with the exception of uterine leiomyosarcoma, there's a signal everywhere. There's 1 or 2 patients that can have cures, complete responses. This is all very short follow-up. You know, no one would call this anything but a complete response at this point. We don't use the word cure till we get out to about 10 years. But to get to cure, you have to start with a complete response. So you can see a signal in all of these different cancer types. So these are all the different targets that are still being investigated. Even with all the work that I just showed you and all the work that's being done, we've only really talked about blocking this pathway, and this pathway. There's quite a number of receptor ligand complexes out there that are still being explored. And that's kind of the state of immune checkpoint at this point. So any questions? So the question is one about cost and what this looks like relative to other therapies for patients with melanoma. What I will tell you is that there are very few treatments for patients with melanoma. So it's not like you're looking at a long list of other chemotherapies to try. Pembrolizumab now runs about $5,000 a dose. At least that's the cost that we pay when we treat patients with it here at the clinical center. I would imagine it's probably a little more on the outside world. And you're talking about getting one dose of that every 2 to 3 weeks for about a year. I think any of these therapies, when you put them all together, the dose strategy and the pricing, because if it's a little more expensive, you don't get it quite as often, or if it's a little less expensive, you're on it for a longer time, it all rounds out to about $100,000 a year. That's, as competition comes out and increases, I would hope that that's going to come down, but it's still kind of at that range for now.
Perhaps you can comment on how long they have to continue the dose.
Sure. So what we don't know, the question was, how long do people need to continue? So the patients with ipilimumab actually got 4 doses and then stopped. Didn't need any other therapy. For pembrolizumab, the current thinking is if someone is responding to give them 2 years of therapy and then stop. And the data is just not conclusive yet on whether they need to continue it or not. It's not even clear that they need to continue it 2 years, but that's kind of the stopping point that they've arrived at. The hope with an immunotherapy, because you're creating a living therapy within someone's body, you're remodeling their T-cell repertoire to attack their cancer, is that if you do it right, and if it sticks, then they don't need any further treatment. So while it may be $100,000 for 1 year or 2 years, it's not $100,000 for 15 years. Almost all, the question is about the toxicities that come when it attacks the colon or the liver or other things. Most of them are reversible. So you can treat the toxicity with steroids, and it does not seem to ameliorate the tumor response. The only side effect that appears to be permanent, and it means that patients have to be on lifelong hormone replacement, is that there are a few patients where the T cells actually attacked the pituitary gland, and they became hypoadrenal. And so those patients, if they're male, have to take testosterone in addition to mineral corticoids to replace their adrenal function and glucocorticoids to address their adrenal function as well. That's a very small number, but that's the only one we've seen that appears to be permanent. The thought why the colitis doesn't exist if the T cells are persistent is that it's tricky, right? Because we don't know how the repertoire changes and grows. But the thought is that once we use the steroids and clear it, the Peyer's patches, which are a normal immune monitoring function of the small bowel and the mucosa-associated lymphoid tissue, then know that that T cell is one that they want to keep the brakes on. And so it doesn't release the brake again. Does that make sense? Any other questions? I didn't put my Twitter handle up on this, but if any of you want to follow, we have both a Twitter account for the surgery branch, which highlights the work coming out by our postdocs all the time, as well as I have my own personal account, which I will tweet from ASCO and AACR, things that are related to immunotherapy for solid cancers, and that's SLGoff_SB or NCI_CCR_SB. And my email's in the directory, so you can find me if you need me. Okay?